The Cerebral Crisis, 10 Critical Protocols for Stroke Survival. In the harrowing theater of neurological trauma, time is not merely money, it is brain tissue. Every passing second of a cerebral ischemia translates to the irreversible death of nearly 2 million neurons, rapidly erasing the essence of who a person is. This is a high-stakes race against biology, where the caregiver serves as the ultimate line of defense. Survival hinges on precision, speed, and identifying the catastrophic warning signs before the window of opportunity slams shut forever, starting with the single most urgent directive in medical history.
Call emergency help immediately, fast signs. The initiation of the emergency response protocol is not merely a procedural step, it is the detonation of the only lifeline available to a human brain undergoing a cataclysmic biological siege. To understand why calling 911 immediately is the supreme directive of stroke care, one must first comprehend the microscopic apocalypse occurring within the skull. A stroke, whether ischemic or hemorrhagic, is a neurovascular event of terrifying velocity. In the case of an ischemic stroke, which accounts for approximately 87% of all incidents, a thrombus or embolus has obstructed a cerebral artery, starving a specific territory of the brain of oxygen and glucose. The result is an ischemic cascade, a complex and rapid sequence of cellular biochemical events that leads to the dissolution of the self. The urgency of the emergency call is dictated by the merciless mathematics of neurology. In the medical community, this is codified by the maxim "time is brain," a concept popularized by neurologist Camilo Gomez in the early 1990s. The statistics underlying this phrase are staggering and horrifying in equal measure. During a typical large vessel ischemic stroke, the average patient loses 1.9 million neurons, 14 billion synapses, and 7.5 miles of myelinated fibers every single minute that treatment is delayed. To put this into a temporal context relative to normal aging, the human brain ages approximately 3.6 years for every hour that passes without reperfusion. Therefore, the act of hesitation, the common human tendency to wait and see if the numbness passes or the slurred speech corrects itself, is functionally equivalent to accelerating the patient's aging process by decades within the span of an afternoon. The caregiver's finger hovering over the dial pad is the difference between a patient returning to their career and a patient requiring lifelong institutional care. The recognition of symptoms relies heavily on the FAST acronym, a public health triumph developed in the late 1990s by a group of stroke physicians in the United Kingdom and subsequently adopted globally. However, a deep investigative look at FAST reveals it is more than a mnemonic, it is a neurological map. Face drooping indicates the failure of the motor cortex or the pathways of the facial nerve, cranial nerve 7, often signifying a lesion in the middle cerebral artery territory.
Arm weakness points to the disruption of the corticospinal tract, the massive highway of motor signals traveling from the brain to the spinal cord. Speech difficulty suggests the involvement of the dominant hemisphere, typically the left side of the brain in right-handed individuals, specifically targeting Broca's area, responsible for speech production, or Wernicke's area, responsible for comprehension. By identifying these signs, the layperson is essentially performing a rapid localization of the brain lesion, providing dispatchers with data that elevates the priority of the ambulance call to the highest level. The history of emergency medical services (EMS) regarding stroke is a fascinating evolution from passive transport to active treatment. Decades ago, an ambulance was simply a ride to the hospital. Today, the call to 911 triggers a complex logistical ballet known as the chain of survival. When a caller articulates the keywords associated with stroke, dispatchers trained in emergency medical dispatch (EMD) protocols immediately categorize the event as a code stroke or stroke alert. This is not administrative jargon. It initiates a pre-hospital notification system. While the paramedics are en route, the receiving hospital is already clearing the CT scanner and paging the neurology team. The goal is to reduce the door-to-needle time, the duration from the patient's arrival at the hospital to the administration of intravenous thrombolysis, TPA. Every minute saved in the pre-hospital phase through immediate calling correlates directly to reduced mortality and disability. Furthermore, the investigative lens must focus on the golden hour and the extended therapeutic windows that define modern neurology. For years, the administration of tissue plasminogen activator, the TPA drug, was strictly limited to a 3-hour window from the onset of symptoms. While this window has expanded to 4.5 hours for eligible patients, and mechanical thrombectomy, physically removing the clot via catheter, can sometimes be performed up to 24 hours later. The efficacy of these treatments follows a steep decay curve. The earlier the intervention, the more brain tissue, known as the penumbra, can be salvaged. The penumbra is the area of the brain surrounding the dead core of the infarct. It is stunned and starving, but not yet dead. It is hanging on by a thread of collateral blood flow.
Calling 911 immediately is the only way to save the penumbra. If the caregiver drives the patient to the hospital themselves, they bypass the EMS assessment, get stuck in traffic, and arrive at the emergency room triage desk as a walk-in, potentially waiting in line behind minor injuries. By calling 911, the patient enters the medical system the moment the paramedics arrive, effectively bringing the emergency room to the patient's living room. We must also analyze the psychological and sociological barriers that prevent immediate action. Studies in behavioral health indicate a phenomenon known as optimism bias, where the brain downplays the severity of a crisis to avoid panic. Family members often attribute the sudden confusion of a stroke to fatigue, dehydration, or medication side effects. This rationalization is the enemy of survival. Additionally, there is the fear of embarrassment, the worry of making a scene for a, quote, false alarm. Educational campaigns have tried to combat this by emphasizing that it is better to be wrong and safe than polite and devastated. In the United States, the average time from symptom onset to hospital arrival has improved but remains suboptimal, largely due to this hesitation interval. The caregiver must override these social instincts and act with ruthless efficiency. The technological future of this entry is equally compelling. We are entering the era of mobile stroke units, or MSUs, specialized ambulances equipped with portable CT scanners and point-of-care laboratories. If a caregiver calls 911 immediately in a city equipped with MSUs, the diagnosis can be confirmed and TPA can be administered right there in the driveway. This effectively eliminates the transport time from the equation, bringing the treatment to the patient rather than the patient to the treatment. This innovation underscores the critical nature of the initial call. Without that trigger, the most advanced mobile technology sits idle in the garage. The integration of artificial intelligence into emergency dispatch is also on the horizon, where AI voice analysis might detect the subtle slurring of speech or the breathless panic of a caller to identify a stroke faster than a human operator, further tightening the timeline. Ultimately, the directive to call emergency help immediately is a command to engage the entire infrastructure of modern medicine. It is an acknowledgement that the human brain is a finite resource.
Melting away under the pressure of ischemia. The phone call is the spark that ignites the engine of rescue. It bridges the gap between a family in their living room and the neurointerventionalist standing ready in the angiography suite. It is the single most consequential action a bystander can take, carrying more weight than any medication or surgery that follows, because without that call, the surgery never happens. The caregiver is the sentinel, and their swift action is the first step in the fight against the darkness of permanent disability.
Keep the patient safe and still. Once the emergency response system has been activated, the caregiver's role shifts from communication to physical stabilization. The directive to keep the patient safe and still sounds deceptively simple, yet it is rooted in complex hemodynamic principles and the fragile physiology of a traumatized brain. In the chaotic moments following the onset of a stroke, the instinct is often to do something active, to move the patient to a bed, to shake them awake, or to drive them to the car. These instincts, while born of love and desperation, are clinically dangerous. To understand why stillness is paramount, one must delve into the concept of cerebral autoregulation and the precarious state of the brain's blood flow during an infarct. Under normal physiological conditions, the human brain possesses a remarkable ability known as autoregulation. This mechanism ensures that the brain receives a constant, steady flow of blood, regardless of fluctuations in the body's systemic blood pressure. Whether a person is sprinting, sleeping, or standing up quickly, the cerebral blood vessels dilate or constrict to maintain equilibrium. However, during a stroke, this autoregulatory mechanism is often shattered, particularly in the affected hemisphere. The brain loses its ability to self-regulate flow. Consequently, cerebral perfusion becomes entirely dependent on systemic blood pressure. This means that the brain is at the mercy of gravity and the heart's output. If a patient is abruptly moved, sat up, or walked to a car, their blood pressure can fluctuate wildly. A sudden drop in pressure, orthostatic hypotension, can starve the penumbra, the salvageable brain tissue, of the critical trickle of blood it is currently relying on. Conversely, a spike in pressure caused by physical exertion or panic can increase the risk of converting an ischemic stroke into a hemorrhagic one, or worsening an existing bleed. Therefore, keeping the patient still is not about comfort, it is about hemodynamic preservation. The caregiver acts as an external regulator for the patient's internal stability. Laying the patient down is usually the safest initial posture because it negates the effects of gravity, ensuring that blood can flow easily to the brain without fighting an uphill battle. This is particularly crucial if the stroke is caused by a blockage. By keeping the patient horizontal, the caregiver maximizes the perfusion pressure to the brain,
buying time for the neurons that are teetering on the brink of death. The only exception, as later protocols will discuss, involves specific positioning for vomiting, but the overarching principle remains: minimize voluntary and involuntary movement. The investigative eye must also examine the environment surrounding the patient. A stroke is a massive neurological shock. The sudden loss of function, the inability to speak, aphasia, or the paralysis of a limb creates an intense surge of catecholamines, stress hormones like adrenaline and cortisol. This fight or flight response causes the heart to race and blood pressure to skyrocket. While some blood pressure elevation is a natural compensatory mechanism during stroke, extreme spikes caused by panic and agitation are detrimental.
By keeping the patient still and creating a calm atmosphere, the caregiver helps dampen this sympathetic nervous system surge. This involves loosening tight clothing, ties, scarves, belts, or restrictive collars, which can impede venous return from the head or restrict breathing mechanics. Restrictive clothing around the neck can stimulate the carotid sinus, potentially causing dangerous reflex drops in heart rate. The act of loosening clothing is a subtle but vital intervention that optimizes the body's circulatory mechanics. Safety in this context also refers to fall prevention, a major but often overlooked aspect of acute stroke care. A stroke often affects the vestibular system or the motor cortex, resulting in sudden, profound loss of balance and coordination, ataxia, or weakness on one side of the body, hemiparesis. The patient may not realize they have lost the ability to support their own weight. There is a frequent and tragic occurrence where a patient attempts to stand up to use the restroom or walk off the numbness, only to collapse. A fall during an acute stroke can lead to secondary trauma, such as hip fractures or subdural hematomas, head injuries, which complicate treatment and drastically worsen the prognosis. The caregiver must act as a physical barrier to this impulse, gently enforcing stillness and reassuring the patient that they must remain down. The concept of avoiding sudden movement extends to the transport phase as well. If the caregiver decides to transport the patient, though this is strongly discouraged in favor of EMS, the movement to the car is fraught with peril. The exertion of walking, the jostling of the vehicle,
and the lack of medical monitoring create a hostile environment for a damaged brain. EMS professionals are trained to move stroke patients using sheet lifts or scoop stretchers to minimize physical stress. They drive with a specific cadence to avoid jarring the patient. When a caregiver keeps the patient still waiting for the ambulance, they are preparing the patient for this professional extraction. They are preserving the metabolic energy of the patient. Every movement requires oxygen and glucose. A brain in the midst of a stroke has no energy reserves to spare. By enforcing stillness, the caregiver is reducing the metabolic demand of the body, allowing every available molecule of oxygen to go to the brain. Historically, the approach to movement during illness has swung like a pendulum. In the 19th and early 20th centuries, strict bed rest was the prescription for almost everything, often to a fault. Modern medicine champions early mobilization and recovery, but in the acute, hyperacute phase, the first minutes and hours, stillness is the guardian of survival. We must also consider the sensory environment. The stillness should extend to the room itself. Bright lights, loud televisions, and frantic shouting all process through the brain, requiring neuronal activity. In a brain experiencing a brownout, this sensory overload can be overwhelming. Part of keeping the patient safe is dimming the lights and speaking in low, soothing tones. This reduces the cognitive load on the failing brain, allowing it to direct its limited resources solely toward survival functions like respiration and basic consciousness. Furthermore, we must address the neurological phenomenon of neglect, which often accompanies right hemisphere strokes. Patients with spatial neglect may be completely unaware of the left side of their body or the left side of space. They might try to move, not realizing their left leg is paralyzed or that there is a wall to their left. They lack the insight to keep themselves safe. The caregiver serves as the external cortex, providing the awareness the patient has lost. Keeping them still prevents them from navigating a world they no longer accurately perceive. In the grand scope of emergency medicine, this step is the bridge between the onset of the catastrophe and the arrival of advanced life support. It is a period of active waiting. It requires the caregiver to exert authority with compassion,
to override the patient's confusion and fear with a firm insistence on immobility. It is a recognition that the patient is currently holding a fragile vase, their own brain function, while standing on a trembling floor. The caregiver's job is to ensure they do not take a step. By freezing the scene, by lowering the metabolic temperature of the room, and by respecting the precarious hemodynamics of the ischemic brain, the caregiver protects the potential for recovery. This stillness is not passivity, it is a calculated physiological intervention that sets the stage for the life-saving measures to come. It preserves the golden hour by ensuring the patient survives the first 10 minutes without compounding the injury. It is the silence before the siren, and it is absolutely vital.
3. Position the body correctly. The physical orientation of a human body during a cerebrovascular accident is not a matter of comfort. It is a matter of fluid dynamics, gravity, and the preservation of the airway, which is the singular gateway to life. When a layperson encounters a stroke victim, the immediate instinct is often to prop them up with pillows to help them breathe, or conversely, to let them slump wherever they have fallen. Both instincts can be fatal. The directive to position the body correctly is a nuanced medical intervention that balances two competing physiological imperatives: maintaining cerebral perfusion, blood flow to the brain, and preventing aspiration, choking on vomit or saliva. To understand the gravity of this step, one must first appreciate the rigid architecture of the human skull and the delicate pressure systems operating within it. The human skull is a fixed bony vault described in neurosurgery by the Monro-Kelly doctrine. This doctrine posits that the cranium has a fixed volume containing three essential components: brain tissue, blood, and cerebrospinal fluid, CSF.
Under normal circumstances, these three exist in a delicate equilibrium. However, a stroke introduces chaos into this closed system. An ischemic stroke causes cytotoxic edema, swelling of the brain cells as they die and fill with fluid. A hemorrhagic stroke introduces a fourth element, a pool of blood that takes up precious space. As pressure within the skull, intracranial pressure, ICP, rises, it begins to crush the healthy brain tissue against the bone. If the pressure becomes too great, the brain can herniate or shift downward into the brainstem, causing instant death. Therefore, the position of the head is a direct lever for managing this pressure. For a conscious patient who is showing signs of a stroke but is alert and breathing, the medical consensus generally favors elevating the head and shoulders slightly, ideally to an angle of roughly 30 degrees. This specific angle is not arbitrary. It is a calculated geometric optimization derived from decades of neurocritical care research. At 30 degrees, the head is elevated enough to facilitate venous drainage. The jugular veins, which carry deoxygenated blood away from the brain, rely partially on gravity. By elevating the head, the caregiver helps drain blood from the rigid box of the skull, thereby lowering the intracranial pressure.
This seemingly minor adjustment acts as a pressure release valve, potentially reducing the swelling that threatens to crush the vital centers of the brain. However, the elevation must be moderate. If the patient is sat up too high, at 90 degrees for instance, gravity may work too well against the arterial blood trying to travel up to the brain. In a patient with low blood pressure or a blockage, an upright posture could starve the penumbra, the salvageable brain tissue, of the trickle of oxygenated blood it needs. Thus, the 30-degree tilt is the Goldilocks zone, high enough to drain the bad blood, low enough to sustain the good blood. This protocol undergoes a radical shift, however, the moment the patient's consciousness wavers or if nausea sets in. The investigative lens must focus here on the physiology of vomiting during a stroke. The brainstem contains a structure known as the area postrema, often called the vomiting center. This area is unique because the blood-brain barrier there is more permeable, allowing it to detect toxins, but it is also highly sensitive to pressure and ischemia. Strokes affecting the posterior circulation, the vertebrobasilar system, often trigger violent, sudden vomiting and vertigo. If a patient is lying on their back, supine, when this occurs, gravity becomes an executioner. The paralyzed or weakened muscles of the throat cannot clear the airway. The vomit pools in the pharynx and is inhaled into the lungs. This is aspiration, and in the context of a stroke, it is often a terminal event. Therefore, for the unconscious or vomiting patient, the recovery position, lateral decubitus position, is mandatory. This technique, developed and refined through the history of resuscitation medicine, utilizes gravity as a tool for airway clearance rather than obstruction. The caregiver must roll the patient onto their unaffected side, if known, though any side is preferable to the back. By placing the patient on their side with the mouth angled downward, fluids, be it saliva, blood, or vomit, drain out of the mouth onto the floor rather than down the trachea into the lungs. The mechanics of the recovery position also address the threat of the tongue. In an unconscious stroke victim, the muscle tone of the tongue fails. Gravity pulls the heavy base of the tongue backward, sealing the pharynx against the posterior pharyngeal wall, effectively strangling the patient from the inside.
The lateral position allows the tongue to fall forward, keeping the airway patent. The history of patient positioning has been a subject of intense debate and evolution. In the early 20th century, stroke patients were often kept strictly flat for weeks, a practice that led to high rates of pneumonia. Conversely, other eras favored immediate sitting to prevent congestion. The definitive answer was sought in the massive head position in stroke trial study, a global investigation involving over 11,000 patients. The results, published in the New England Journal of Medicine, revealed that for the average stroke patient, the difference between lying flat and sitting up did not drastically alter long-term disability outcomes once inside the hospital. However, in the pre-hospital setting, the living room, the bathroom floor, the office, the rules of immediate survival take precedence over long-term rehabilitation statistics. The immediate threat is the airway. The caregiver is not treating the stroke, they are maintaining the chassis in which the brain resides. Implementing this care requires a calm, forceful physicality. The caregiver often has to manipulate a dead weight. A stroke patient with hemiplegia, paralysis on one side, is difficult to move. The caregiver must support the head at all times, treating the neck with the reverence to a spinal injury, although stroke does not inherently damage the spine. When positioning the patient on their side, the caregiver should bend the top leg at the knee to act as a kickstand, preventing the patient from rolling back onto their stomach, which would compress the chest and impede the mechanics of breathing. This is a tactile, hands-on intervention. It is the physical manifestation of life support. Furthermore, we must consider the psychological aspect of positioning. A patient experiencing a stroke is often in a state of terror and vertigo. The world is spinning. By stabilizing the body, using pillows to prop the back, ensuring the head is supported, the caregiver provides a sensory anchor. This reduction in physical chaos can help lower the patient's heart rate and blood pressure, feeding back into the positive loop of neuroprotection. Conversely, leaving a patient slumped in a chair with their head lolling forward restricts the carotid arteries and compresses the trachea, compounding the injury with every breath.
The future of this specific intervention lies in the development of smart pre-hospital equipment. Ambulances and perhaps eventually smart home systems will utilize beds and surfaces that automatically adjust the patient's angle based on real-time biometric feedback. Imagine a scenario where a wearable device detects a stroke and instructs a smart bed to elevate the head to exactly 30 degrees, or alerts a caregiver
caregiver to turn the patient based on acoustic detection of airway obstruction. Until that technological horizon is reached, however, the geometry of survival is in the hands of the bystander. The decision to tilt the head or roll the body is a decision about the physics of blood and air. It is a silent, structural battle to keep the brain fed and the lungs clear, bridging the perilous gap between the onset of symptoms and the arrival of professional help.
4. Do not give food, water, or medicine. Of all the instincts ingrained in the human experience, the drive to nurture through sustenance is perhaps the most primal. When a loved one is in distress, pale and weak, the overwhelming compulsion is to offer a glass of water, a cup of sweet tea, or a morsel of food to keep their strength up. In the context of a stroke, this act of love is a biological Trojan horse that can kill faster than the clot itself. The directive "do not give food, water, or medicine," medically known as NPO, nil per ors, or nothing by mouth, is an absolute non-negotiable commandment of acute neurology. To violate it is to risk drowning the patient in their own fluids or poisoning them with medication that turns a manageable stroke into a fatal hemorrhage. The physiological justification for this prohibition lies in the complexity of the swallowing mechanism, a neurological symphony known as deglutition. We take swallowing for granted because it occurs automatically, roughly 600 to 1,000 times a day. However, a deep investigative look into the anatomy of a swallow reveals it to be one of the most complex neuromuscular activities in the human body. It involves the precise coordination of 50 pairs of muscles and 6 different cranial nerves, V, 7, 9, 10, 11, and 12, all executing a sequence of movements within less than 2 seconds. The tongue must propel the bolus back, the soft palate must rise to seal off the nose, the larynx voice box must elevate, and crucially, the epiglottis must flip down to cover the trachea, windpipe, like a trapdoor. A stroke acts as a sledgehammer to this delicate machinery. Dysphagia, or difficulty swallowing, affects up to 65% of acute stroke patients. The neurological damage disrupts the timing of the sequence. The signal to the epiglottis may be delayed by a fraction of a second. In that tiny window of error, the water offered by a well-meaning caregiver does not go down the esophagus to the stomach. It pours directly into the trachea and down into the bronchial tree of the lungs. This is called aspiration. The investigative reality is that the patient may not even cough. This phenomenon, known as silent aspiration, is particularly insidious. The stroke may have dulled the sensation in the throat, so the patient drowns quietly with no outward sign of distress until they develop a fever days later. The consequences of aspiration are catastrophic. The lungs are spongy.
Sterile organs designed for gas exchange, not for liquid storage. When water enters, it can cause drowning on a microscopic level. If food or stomach contents are aspirated, the result is aspiration pneumonia. The acidity of stomach contents causes a chemical burn to the delicate lung tissue, Mendelssohn syndrome, followed by a bacterial invasion from the oral flora. Aspiration pneumonia is a leading cause of death in stroke survivors, often claiming lives weeks after the initial event has been stabilized. It turns a neurological recovery into a respiratory failure. Therefore, the glass of water offered in the living room becomes the seed of the infection that kills the patient in the ICU. The prohibition extends strictly to medication, a point that requires aggressive deconstruction of popular medical myths. There is a pervasive cultural belief, fueled by decades of public health campaigns regarding heart attacks, that one should chew an aspirin at the first sign of trouble. For a myocardial infarction, heart attack, this is correct. For a stroke, this action is like playing Russian roulette with a fully loaded gun. This is because strokes come in 2 varieties: ischemic, clot, and hemorrhagic, bleed. In a pre-hospital setting, it is impossible, absolutely impossible, to distinguish between the two without a CT scan. If the patient is suffering from a hemorrhagic stroke, roughly 13% of cases, a blood vessel has ruptured in their brain. The brain is actively bleeding into the skull. Aspirin is a potent antiplatelet agent. It thins the blood and prevents clotting. If a caregiver administers aspirin to a patient with a hemorrhagic stroke, they are effectively removing the body's only defense mechanism against the bleed. They are accelerating the hemorrhage, increasing the volume of blood crushing the brain, and likely sealing the patient's death warrant. Even if the stroke is ischemic, the administration of pills poses a choking hazard due to the aforementioned dysphagia. The risk-benefit analysis is entirely skewed toward catastrophe. No medication, not aspirin, not blood pressure pills, not diabetic sugar tabs, should ever cross the lips of a stroke suspect until a doctor has viewed the brain scan. The cultural and psychological investigation of this entry reveals a profound conflict for the caregiver. Denying water to a person who is asking for it, who may be parched and pleading, feels like an act of cruelty.
It contradicts the role of the caregiver. In many cultures, food is the language of care. To withhold it is to abandon the sufferer. The caregiver must intellectually override this emotional imperative. They must understand that dry care is the highest form of protection. They can swab the lips with a wet sponge to provide comfort without volume, but nothing must be swallowed.
This protocol also touches upon the water swallow test used in hospitals. Before a stroke patient is allowed to eat, they undergo a rigorous screening, often involving the Yale Swallow Protocol, where nurses observe the drinking of 3 ounces of water for any sign of coughing or voice change. A wet voice indicates fluid on the vocal cords. In the pre-hospital environment, the caregiver lacks the training to perform this screen. The assumption must always be that the swallowing mechanism is broken until proven otherwise. Looking toward the future, the management of acute dysphagia is an area of intense technological development. Researchers are exploring pharyngeal electrical stimulation, where electrodes stimulate the throat to wake up the swallowing reflex and reorganize the motor cortex. Additionally, AI-driven applications are being developed that can analyze the sound of a patient's swallow via a smartphone microphone to detect aspiration risks instantly. Until such tools are ubiquitous, the NPO rule remains the starkest, most counterintuitive, and most vital barrier against secondary death. Ultimately, this entry is a lesson in restraint. In an age where we are conditioned to do something to help, the most powerful intervention often lies in what we do not do. By withholding that glass of water, the caregiver is protecting the lungs from infection and the brain from hemorrhage. They are preserving the patient's eligibility for advanced treatments like thrombolysis, which has strict exclusion criteria regarding recent intake. It is a discipline of denial, a harsh but necessary guardrail that ensures the patient survives the ambulance ride without a flooded airway or a thinned-out bleed. It is the discipline of saving the patient from the dangerous kindness of a drink.
5. Monitor breathing and consciousness. In the terrifying interim between the frantic call to emergency services and the arrival of the paramedics, the caregiver transitions from a passive observer to the sole guardian of the patient's biological existence. The directive to monitor breathing and consciousness is not a passive activity. It is a high-stakes vigil that requires a profound understanding of the relationship between the brainstem and the respiratory drive. To fully grasp the gravity of this responsibility, one must descend into the anatomy of the human brain, specifically the medulla oblongata and the pons. These primal structures, located at the base of the skull, constitute the reptilian brain. They are the control centers for the autonomic functions that keep us alive without conscious thought: heart rate, blood pressure, and most critically, respiration. When a massive stroke occurs, particularly a hemorrhagic event or a blockage in the basilar artery, the resulting pressure or ischemia can directly assault these vital centers. The brain, swelling within the rigid confines of the cranium, may herniate downward, compressing the brainstem against the bone. The result is a catastrophic failure of the respiratory drive. The patient does not simply fall asleep. Their fundamental biological programming to inhale is being deleted in real time. This is why monitoring is not just looking, it is listening, feeling, and interpreting the subtle acoustical and mechanical signs of a shutting down system. The caregiver must become a human biometric sensor, detecting the difference between a deep sleep and a comatose descent toward respiratory arrest. The investigation of consciousness in a stroke patient relies on a framework known as the Glasgow Coma Scale, or GCS. While a layperson is not expected to calculate a GCS score, they are essentially performing a simplified version of it. The scale measures 3 responses: eye-opening, verbal response, and motor response. A drop in consciousness is often the first indicator that the stroke is expanding or that intracranial pressure is spiking. The caregiver must constantly engage the patient. Can you squeeze my hand? Open your eyes. What is your name? To track the trajectory of their alertness. A patient who was mumbling 2 minutes ago but is now unresponsive to pain, such as a pinch on the shoulder, has crossed a critical threshold.
This decline suggests that the reticular activating system, RAS, the network of neurons in the brainstem that regulates wakefulness, is being compromised. The most harrowing aspect of this monitoring is the recognition of respiratory failure. It rarely happens instantly. Often, the patient will exhibit Cheyne-Stokes respiration, a distinct and ominous pattern of breathing characterized by a gradual increase in depth and rate, followed by a decrease, resulting in a temporary stop in breathing, apnea, before the cycle repeats. This is the sound of the brainstem struggling to regulate carbon dioxide levels in the blood. Even more terrifying is agonal breathing, gasping, labored, irregular breaths that can sound like snoring or snorting. To the untrained ear, a snoring patient might seem to be sleeping peacefully. In the context of a stroke, this snore is often the tongue collapsing against the pharynx as the brain forgets how to keep the airway open. It is a sign of impending death. The caregiver must distinguish this from normal sleep. If the patient cannot be roused and is making these sounds, they are not sleeping, they are dying. This leads us to the ultimate intervention, cardiopulmonary resuscitation, CPR. The mandate to be ready to perform CPR is a call to bridge the gap between life and death. If the patient stops breathing or if their breathing becomes agonal and ineffective, the heart will soon follow. Hypoxia, lack of oxygen, will cause the heart muscle to fail, leading to cardiac arrest. In this scenario, the stroke is no longer the primary concern, the arrest is. The caregiver must immediately initiate chest compressions. The modern protocol, emphasized by the American Heart Association, is hands-only CPR for untrained bystanders. The focus is shifted away from mouth-to-mouth ventilation toward high-quality, uninterrupted chest compressions. The mechanics of CPR are a brutal but necessary substitute for the heart's function. By compressing the chest at a depth of at least 2 inches and a rate of 100 to 120 beats per minute, the caregiver is manually squeezing the heart between the sternum and the spine, forcing
forcing blood up the carotid arteries to the brain. In a stroke patient, this is doubly critical. The brain is already ischemic. It is starving. If blood flow stops completely due to cardiac arrest, the timeline for permanent brain death accelerates from minutes to seconds.
The caregiver effectively becomes the patient's heart. It is an act of immense physical exertion and psychological fortitude. The sensation of ribs cracking, a common occurrence in effective CPR, can be traumatizing, but the caregiver must push through the tactile horror to maintain perfusion pressure. Historically, the evolution of resuscitation is a testament to humanity's refusal to accept death as a finality. From the early 18th century methods of using bellows to blow air into the lungs, to the 1960s development of closed-chest cardiac massage by Dr. James Elam and Dr. Peter Safar, we have constantly sought ways to reverse the terminal pause. Today, we understand that time is myocardium and time is brain. The bystander who performs CPR is the most important link in the chain of survival. Statistics show that immediate bystander CPR can double or triple a patient's chance of survival. Yet in stroke scenarios, there is often hesitation. Family members fear hurting the patient or are paralyzed by the thought that the stroke has already done the damage. This fatalism must be rejected. The brain is resilient, but only if it is fed. We must also explore the psychological rescue trauma experienced by the caregiver. Watching a loved one's consciousness flicker and fade is a profound shock. The responsibility of monitoring breathing creates a hypervigilant state where every second of silence feels like an hour. The caregiver is often fighting their own panic response to maintain the focus required to count breaths and feel for a pulse. This pulse check, typically performed at the carotid artery in the neck, is technically difficult for laypeople, especially when their own hands are shaking with adrenaline. Modern guidelines suggest that if the patient is unresponsive and not breathing normally, one should assume cardiac arrest and begin compressions immediately, rather than wasting precious seconds hunting for a pulse that may be too weak to feel. The future of monitoring is moving rapidly toward technological augmentation. We are entering the era of contactless monitoring. Smart speakers and home assistants like Alexa or Google Home are being trained to detect the specific audio signature of agonal breathing. In the near future, a room might hear a stroke patient gasping and automatically alert emergency services or instruct the caregiver to start CPR. Wearable technology, such as smartwatches,
already detects falls and irregular heart rhythms. The next generation will likely monitor oxygen saturation, SpO2, and respiratory rate in real time, vibrating to alert a family member if a patient's breathing drops below a safe threshold. Furthermore, the integration of artificial intelligence into emergency dispatch allows 911 operators to guide caregivers with unprecedented precision. AI voice analysis can detect the stress levels and hesitation in a caller, prompting the dispatcher to use more assertive, rhythmic counting to help the caregiver maintain the correct compression rate. Until these technologies are ubiquitous, however, the safety of the patient rests entirely on the eyes and ears of the observer. Monitoring breathing is the line in the sand. It is the commitment to stand watch over the failing machinery of the body, ready to manually operate the pump of life if the biological engine stalls. It is the ultimate act of defiant care.
6. Record the exact time symptoms started. In the high-tech sterile world of neurointerventional medicine, the most critical piece of data does not come from an MRI machine, a blood test, or a genetic screen. It comes from a clock on a living room wall, a glance at a wristwatch, or the timestamp on a text message. The directive to record the exact time symptoms started, medically referred to as the last known well (LKW) time, is the fulcrum upon which all stroke treatment pivots. It is a rigid, unforgiving chronological barrier that dictates whether a patient is a candidate for a miraculous recovery or if they are destined for lifelong disability. To understand why this timestamp is treated with such reverence, one must investigate the pathophysiology of the ischemic penumbra and the dangerous pharmacology of thrombolytic drugs. The concept of time is brain is not a metaphor, it is a calculation of cellular necrosis. When a clot blocks a cerebral artery, the core of the infarction, the area of the brain directly deprived of all blood flow, dies within minutes. However, surrounding this dead core is a large area of tissue known as the penumbra. The penumbra is stunned, electrically silent, and starving, but it is still structurally intact. It is being kept alive by collateral circulation, tiny backroads of blood vessels that provide just enough oxygen to prevent immediate death. This tissue is salvageable, but it has an expiration date. As time takes by, the penumbra is relentlessly recruited into the dead core. The goal of all acute stroke therapy is to dissolve or remove the clot before the penumbra disappears. This brings us to the history and pharmacology of TPA, the clot-busting drug. Approved by the FDA in 1996 following the landmark NINDS, National Institute of Neurological Disorders and Stroke trial, TPA changed stroke from an untreatable condition to a treatable emergency. However, TPA is a double-edged sword. It works by activating plasminogen to form plasmin, an enzyme that breaks down the fibrin mesh binding a clot together. But as the brain tissue dies, the blood-brain barrier, the defensive wall that prevents toxins and drugs from entering the brain, begins to disintegrate. If TPA is administered after this barrier has broken down, typically after 4.5 hours, the drug can leak into the brain tissue and cause a massive secondary hemorrhage, instead of saving the brain. The drug causes a catastrophic bleed. Therefore, the last known well time is the safety lock on the weapon. Doctors operate under strict windows, generally 0 to 3 hours for TPA, extended to 4.5 hours for eligible patients, and up to 24 hours for mechanical thrombectomy, physically pulling the clot out with a stent retriever. If the caregiver cannot provide a precise time, or if the time falls outside these windows, the patient may be disqualified from these treatments to avoid the risk of killing them with the cure. This makes the caregiver's report the single most important variable in the triage process. The investigation into determining the LKW is often a feat of detective work. The medical definition of LKW is crucial and often misunderstood. It is not the time the symptoms were discovered, it is the last time the patient was seen to be normal. Consider the wake-up stroke, a nightmare scenario accounting for nearly 25% of all strokes. A patient goes to bed at 10 p.m. appearing normal and wakes up at 7 a.m. paralyzed. The time of discovery is 7 a.m., but the last known well time is 10 p.m. Because the stroke could have happened at 10:01 p.m., the patient has technically been stroking for 9 hours, placing them well outside the TPA window. The caregiver must be precise. "I found him at 2 p.m." is useless if the last time anyone saw him was at breakfast at 8 a.m. This entry requires the caregiver to become a forensic chronicler. They must cross-reference reality. "We were watching Jeopardy when he slumped over." The doctor can look up the broadcast time of Jeopardy to pinpoint the onset. "He sent me a text message at 4:15 p.m. that made sense, but the one at 4:30 p.m. was gibberish." That text message log becomes a medical record. The exact minute matters. A patient arriving at the hospital with 10 minutes left in the treatment window triggers a swarm response, where teams run down hallways to push the drug before the clock strikes. If the time is vague, sometime around lunch, the medical team is paralyzed by uncertainty. The philosophical implication of this entry is the tyranny of linear time in modern medicine. In no other condition is the calendar and the clock so directly correlated to the outcome. We are forcing a chaotic biological event into a strict chronological framework. This has led to the stroke code ethos in hospitals, where processes run in parallel rather than series to shave off seconds. The door-to-needle time goal is less than 60 minutes. Every minute of delay in the hospital, waiting for an elevator, waiting for a lab result, is a failure of the system. But the clock starts with the caregiver. If the caregiver delays recognizing the symptoms or fails to note the time, the hospital's speed is irrelevant. However, the future of stroke care is attempting to break free from the rigid constraints of the clock. We are moving from a time-based paradigm to a tissue-based paradigm. New advanced imaging techniques such as CT perfusion and MRI diffusion-perfusion mismatch allow doctors to see the penumbra directly. If the scan shows a large area of salvageable tissue, it may not matter if the clock says 6 hours or 12 hours, the tissue is still alive. The DAWN and DEFUSE 3 trials have revolutionized this, expanding the window for mechanical thrombectomy up to 24 hours for select patients. This technological evolution addresses the tragedy of the wake-up stroke. Using MRI sequences like FLAIR, fluid attenuated inversion recovery, neuroradiologists can estimate the age of a stroke. If the stroke is visible on one type of scan but invisible on another, it indicates the stroke is fresh, potentially allowing treatment even without a known onset time. This is the wake-up trial protocol. Yet, despite these advances, the last known well remains the gold standard for immediate triage. Advanced imaging takes time and isn't available at every community hospital. The simple verbal report from a witness is the fastest way to categorize a patient. Culturally, this entry highlights the need for public awareness. We teach people CPR, but we rarely teach them to check their watch. The act of checking the time when a loved one collapses should be as ingrained as calling 911. It is an administrative act that carries life-saving weight. It turns the caregiver into a partner in the medical decision-making process. When the neurosurgeon asks, "When did this start?" and the caregiver answers, 1:14 p.m. exactly, they are handing the surgeon the key to unlock the medicine cabinet. They are effectively authorizing the rescue. Ultimately, recording the time is about establishing the boundaries of hope. It provides the medical team with the coordinates they need to navigate the dangerous waters of reperfusion therapy. It prevents the tragedy of a patient arriving too late simply because the timeline was murky.
It is a testament to the fact that in the face of a stroke, we are not just fighting a disease, we are fighting the fourth dimension. The caregiver's watchful eye on the clock is the first victory in that war. 7. Prepare medical information quickly. In the chaotic, high-velocity environment of the emergency room, information is a commodity as valuable as oxygen. When a stroke patient is wheeled through the sliding glass doors, they are often entering a medical blackout. They may be aphasic, unable to speak due to damage in Broca's area, they may be unconscious, or they may be in a state of profound cognitive disarray. To the receiving team of neurologists and emergency physicians, this patient is a black box, a biological cipher with unknown variables. The directive to prepare medical information quickly is the process of unlocking that box. It is the act of providing the tactical intelligence required to launch a counterattack against the stroke without inadvertently killing the patient in the process. The necessity of this step is rooted in the extreme volatility of acute stroke treatments, specifically the administration of intravenous thrombolysis, TPA.
As established, TPA is a potent enzyme that dissolves blood clots. However, it is a non-specific agent. It does not know the difference between a pathological clot in the brain and a protective clot sealing a recent surgical wound or a stomach ulcer. Therefore, the administration of TPA is governed by a rigorous, almost draconian checklist of inclusion and exclusion criteria. This is where the caregiver's role as the historian becomes the linchpin of survival. The doctor needs to know with absolute certainty and within minutes if the patient has a history of intracranial hemorrhage, recent head trauma, gastrointestinal bleeding, or major surgery within the last 14 days. A yes to any of these questions transforms the cure into a lethal poison. If a caregiver is unsure or if the medical records are inaccessible, the doctor may be forced to withhold the drug to avoid causing a fatal bleed. The absence of information leads to the paralysis of treatment. The most critical data point in this investigative profile is the patient's current medication list, specifically the use of anticoagulants. In the modern pharmacological landscape, millions of Americans are prescribed blood thinners for atrial fibrillation, deep vein thrombosis, or pulmonary embolism. For decades, the standard was warfarin, Coumadin, a drug that requires regular blood monitoring, INR. Today, the market is dominated by direct oral anticoagulants like Eliquis, apixaban, or Xarelto, rivaroxaban.
These drugs are highly effective at preventing strokes, but if a patient on these drugs suffers a stroke, a breakthrough event, they are generally disqualified from receiving TPA because their blood is already too thin. Administering a clot buster on top of a blood thinner is essentially guaranteeing a hemorrhagic conversion. However, there is a nuance. If the patient has missed their last few doses, or if the last dose was taken more than 48 hours ago, they might still be eligible. Only the caregiver knows this timeline. The electronic health record, EHR, might say prescribed Eliquis, but it cannot say taken this morning. The caregiver's ability to hand the doctor a list and say he took his blood thinner at 8 a.m. today provides the definitive stop sign that saves the patient from a catastrophic bleed. Conversely, saying he hasn't refilled that prescription in a week might open the door to life-saving therapy. This is the medication reconciliation performed at the speed of light, and it is fraught with peril. We must also consider the wallet biopsy, the rapid identification of the patient. In a fragmented healthcare system like that of the United States, medical records are often siloed. A patient may have had brain surgery at Hospital A 3 years ago, but is now being treated for a stroke at Hospital B. Hospital B's computers do not talk to Hospital A's computers. If the patient arrives as a John Doe, the medical team is flying blind. By immediately providing a driver's license or ID, the caregiver allows the registration clerks to merge the patient's identity with their digital medical history, potentially pulling up critical data about allergies, baseline creatinine levels vital for contrast CT scans, and past imaging. A rapid look at an old MRI can tell a doctor if a spot on the brain is a new stroke or an old scar, preventing misdiagnosis. The scope of medical information extends into the realm of the invisible, allergies to contrast dye. To visualize the blood vessels in the brain, CT angiography, doctors inject an iodine-based contrast agent. If the patient has a severe anaphylactic allergy to this dye, the scan can send them into shock, compounding the stroke with cardiovascular collapse. The patient cannot speak to warn the team. The caregiver is the voice of the immune system. Furthermore, the history of baseline function is vital. The neurological team needs to know what the patient was like yesterday.
Did they already have a slight limp from an old hip surgery? Was their speech always a bit slow? Without this baseline, doctors might misinterpret old symptoms as new stroke signs, leading to aggressive and unnecessary interventions. The historical context of medical record keeping highlights the urgency of this entry. We have moved from the era of paper charts, physically driven from room to room, to the digital age of the electronic medical record, EMR. While EMRs promised universal access, the reality is a landscape of proprietary systems, Epic, Cerner, Meditech, that struggle to communicate. This lack of interoperability is a systemic failure that the caregiver must manually bridge. The Go Bag or the File of Life, a magnetic red folder kept on the refrigerator, are analog solutions to a digital problem. They represent a culture of preparedness that acknowledges the fragility of the healthcare infrastructure. The philosophical implication here is the concept of the quantified self. In an emergency, a human being is reduced to a set of data points: age, weight, allergies, medications, and time. The richness of their personality, their fears, and their loves are temporarily suspended in favor of their biological metrics. The caregiver's task is to provide these metrics with ruthless efficiency. It is a moment where administrative precision becomes an act of love. Fumbling for an insurance card or guessing at a medication name wastes door-to-needle time. Every minute spent hunting for information is a minute the brain spends dying. Looking toward the future, technology aims to eliminate the historian bottleneck. We are approaching the age of the Smart Health ID. Initiatives like the Blue Button Data Project and the integration of health records into smartphone operating systems like Apple Health allow patients to carry their entire medical history in their pocket. In the event of a stroke, a paramedic could theoretically tap their device against the patient's phone or smartwatch to instantly download allergies, medications, and recent surgeries.
Further out, bioimplantable RFID chips could store this data under the skin, ensuring that even a naked, unconscious patient can speak their medical history to a scanner. Until that seamless future arrives, the burden remains on the family. The directive to prepare information is a call for logistical competence in the face of emotional devastation.
It requires the caregiver to suppress their panic and locate the pill bottles, the insurance card, and the list of surgeries. It demands that they treat the ambulance ride not just as a transport, but as a briefing session. By handing the stroke team a complete dossier upon arrival, the caregiver is effectively clearing the runway, removing the debris of uncertainty so that the medical team can land the plane. It is the silent administrative victory that allows the clinical miracle to occur. 8. Support hospital treatment and early rehab. Once the storm of the acute phase has passed, after the clot has been busted or the bleed stabilized, the patient enters a new protracted theater of war, the hospital ward and the rehabilitation gym. Entry number 8, support hospital treatment and early rehab, marks the transition from saving the life to salvaging the quality of that life. This phase is governed by the principles of neuroplasticity, the brain's remarkable but demanding ability to rewire itself. The caregiver's role shifts from emergency responder to coach, advocate, and endurance partner. To understand the weight of this responsibility, one must dive deep into the biological mechanisms of recovery and the harsh, sterile reality of the post-stroke environment. The immediate post-acute phase often takes place in the intensive care unit, or ICU, or a dedicated stroke unit. Here, the investigation focuses on the concept of permissive hypertension and strict neurological monitoring. Doctors may intentionally keep the patient's blood pressure high to force blood through the narrowed vessels to the recovering brain. The caregiver must understand that these numbers, which would be alarming in a healthy person, are therapeutic here. Supporting hospital treatment means adhering to these counterintuitive protocols. It involves tolerating the fishbowl existence of the ICU, the constant alarms, the hourly neurological checks, pupil flashes, limb commands that result in sleep deprivation and ICU delirium. This delirium is a psychotic state brought on by the environment, and the caregiver is often the only tether to reality, orienting the patient to time and place, preventing the hallucinations from becoming permanent psychological scars. As the patient stabilizes, the focus shifts immediately to rehabilitation. This is not merely exercise, it is a neurological intervention designed to exploit the critical window of neuroplasticity. Research, including animal models and human imaging, suggests that the brain is in a heightened state of plasticity for the first 3 to 6 months following an injury. During this time, the brain is desperate to forge new connections. It is releasing growth factors like BDNF, brain-derived neurotropic factor, that encourage dendritic sprouting. However, this rewiring is use-dependent. If a neural pathway is not used, it is pruned away. This is the biological basis of the use it or lose it principle.
The caregiver's support of early rehab is crucial because of the exhaustion factor. Post-stroke fatigue is a crushing, bone-deep weariness that makes even lifting a finger feel like moving a mountain. The patient will want to quit. They will want to sleep. The medical team will push them, but the caregiver must reinforce that push. This involves understanding the 3 pillars of rehab: physical therapy, PT, for gross motor function and mobility; occupational therapy, OT, for fine motor skills and activities of daily living, ADLs, like buttoning a shirt or holding a fork; and speech-language pathology, SLP, for swallowing, dysphagia, and communication, aphasia. A major investigative point in this entry is the controversy and science of how early is early. The AVERT trial, a massive global study, shook the foundations of stroke care by suggesting that while early mobilization is good, too early, within 24 hours, and too intense mobilization might actually harm the patient by reducing cerebral blood flow when they stand up. Thus, supporting early rehab requires a nuanced balance. It means following the doctor's specific prescription for movement. It means sitting in a chair for meals to build core strength, but not walking a marathon on day 2. The caregiver acts as the monitor of this balance, encouraging effort while watching for signs of metabolic collapse. The psychological dimension of this phase is profound. The patient is often mourning the death of their former self. They may face hemiplegia, paralysis of one side, neglecting the left side of their world entirely, hemispatial neglect. They may have lost the ability to speak, aphasia, trapping a fully intact intellect inside a silent cage. This leads to post-stroke depression, which affects 1/3 of survivors and significantly hampers recovery. Supporting treatment means advocating for antidepressants or counseling, recognizing that the will to recovery is a chemical process as much as a psychological one. The caregiver must learn the techniques of constraint-induced movement therapy, CIMT, where the good arm is restrained to force the brain to use the bad arm. This is frustrating and often tear-inducing work. The caregiver must be the firm hand that insists on the therapy, understanding that the frustration is the sound of the brain trying to heal. Historically,
rehabilitation has evolved from a philosophy of convalescence, where patients were sent to rest homes to be comfortable until they died, to a philosophy of active reconstruction. This shift was largely driven by the survival rates of soldiers in World War II and the polio epidemics, which created a population of young disabled people who demanded a return to society. Today, stroke rehab is a high-tech discipline.
We are seeing the integration of robotics, such as the Locomot, a robotic gait trainer, and exoskeleton suits that move the patient's legs for them, providing the high-repetition sensory feedback the spinal cord needs to relearn walking. The future of supporting rehab lies in the merging of man and machine. Brain-computer interfaces, BCIs, are being developed that decode the patient's intention to move and transmit that signal to a robotic arm or even back to their own muscles via functional electrical stimulation, FES. Virtual reality, VR, is entering the hospital room, allowing a bedbound patient to practice walking in a virtual forest, stimulating the mirror neurons in the brain without the risk of falling. The caregiver of the future will not just help with stretches, they will be setting up the VR headset and calibrating the neural interface. However, the most critical support is the translation of hospital skills to the real world. The hospital is a safe, flat, sterile environment with grab bars everywhere. The real world is messy, uneven, and chaotic. The caregiver must attend the therapy sessions to learn the transfers, how to move the patient from bed to wheelchair, from wheelchair to toilet, without injuring their own back or dropping the patient. They become an apprentice therapist. They learn to thicken liquids to the consistency of honey to prevent aspiration. They learn to speak in short, clear sentences to bridge the aphasia gap. Ultimately, supporting hospital treatment and early rehab is about maintaining the momentum of survival. The stroke knocked the patient down, the medicine kept them alive, but the rehab is what gets them back up. It is a grueling, repetitive, and often unglamorous process of reclaiming function 1 millimeter at a time. The caregiver is the witness to this struggle, the one who celebrates the twitch of a finger that hasn't moved in weeks, recognizing it for what it is, a signal flare from the brain, announcing that the connection has been reestablished. It is the commitment to the long haul.
Understanding that the hospital discharge is not the finish line, but merely the starting gun for the marathon of recovery.
9. Prevent complications at home. The discharge from the hospital marks a profound psychological and logistical shift in the stroke narrative. While the acute phase is defined by the high-tech cacophony of the intensive care unit, the rhythmic beeping of cardiac monitors, the hiss of ventilators, and the constant surveillance of medical professionals, the return home is defined by a terrifying silence. It is in this silence that the second wave of mortality often strikes. The directive to prevent complications at home is a command to transform the domestic environment into a subacute medical facility. The home, typically a sanctuary of comfort, must be reimagined as a defensive perimeter against the opportunistic pathologies that prey on the immobilized and the neurologically compromised. The caregiver, stripped of the immediate support of nurses and doctors, becomes the sole barrier between the patient and a host of secondary killers, chief among them being pressure ulcers, deep vein thrombosis, and aspiration pneumonia. To understand the gravity of this responsibility, one must first investigate the microscopic warfare occurring at the level of the skin. The formation of a pressure ulcer, colloquially known as a bed sore or clinically as a decubitus ulcer, is a gruesome testament to the fragility of human tissue under gravity. The human body was designed for motion. It was not engineered to lie static on a mattress for days on end. When a stroke patient suffering from hemiplegia, paralysis, lies in one position, the weight of their bones, specifically the sacrum, the heels, and the hips, compresses the soft tissue against the surface of the bed. This compression exceeds the capillary closing pressure, approximately 32 millimeters of mercury. Effectively, the blood vessels are squeezed shut. The tissue is starved of oxygen and nutrients, ischemia. If this pressure is not relieved within 2 hours, the cells begin to die. This is not a slow process, it is a rapid necrotizing cascade. The caregiver's primary weapon against this is the turn clock. The standard protocol of turning a patient every 2 hours, Q2H, is a grueling, sleep-depriving regimen that dates back to the observations of Florence Nightingale during the Crimean War. However, modern nursing science reveals that the turn is more complex than a simple roll. It involves the physics of shear and friction. If a caregiver drags the patient across the sheets, the friction can strip the epidermis,
while the shearing force tears the blood vessels beneath the skin. The investigative reality is that a stage 4 pressure ulcer, a wound so deep it exposes muscle and bone, can originate from a single night of neglect. These wounds are not merely painful, they are portals for sepsis, a systemic infection that kills thousands of stroke survivors annually. The caregiver must become a dermatologist, inspecting the skin daily for non-blanchable erythema, redness that does not turn white when pressed, which is the biological distress signal of dying skin. Parallel to the threat of the skin is the threat of the blood. Deep vein thrombosis, DVT, is a specter that haunts the recovery phase. Under normal physiological conditions, the venous blood in the legs is pumped back to the heart by the contraction of the calf muscles, the peripheral heart. In a paralyzed leg, this pump is broken. The blood pools, entering a state of stasis. According to Virchow's triad, stasis combined with the hypercoagulability often present after a stroke creates the perfect storm for clot formation.
If a clot forms in the deep veins of the leg, it is a ticking time bomb. If it dislodges, it travels up the vena cava, through the right side of the heart, and lodges in the lungs. This is a pulmonary embolism, PE, a catastrophic event that can cause sudden death in a recovering patient who seemed to be doing well. Preventing this at home requires a mix of mechanical and pharmacological vigilance. The caregiver must ensure the patient wears compression stockings, TED hose, or uses pneumatic compression devices if prescribed. But more importantly, they must be vigilant for the subtle signs of DVT, warmth, swelling, or redness in one leg. The tragedy of PE is that it is often the result in successful rehabilitation. As the patient begins to move more, the movement dislodges the clot that formed during the weeks of immobility. Thus, the complication arises at the moment of perceived victory. The caregiver must balance the need for mobilization with the awareness of this silent vascular threat. Furthermore, the home environment is the breeding ground for aspiration pneumonia, the silent choker. As discussed in previous entries, dysphagia, swallowing difficulty, is common. In the hospital, diet is strictly controlled. At home, standards often slip. A well-meaning relative might offer a drink of thin water, or the patient might be fed while lying too flat.
The result is the inhalation of bacteria-laden oral secretions into the lungs. Unlike the dramatic choking of a blocked airway, aspiration can be silent. The patient simply develops a low-grade fever and a wet cough days later. By then, the lungs are turning into a swamp of bacterial growth. The caregiver must enforce the chin-tuck maneuver during swallowing and adhere strictly to thickened liquid protocols, transforming mealtime from a social event into a clinical procedure. We must also analyze the phenomenon of contractures to hardening of the body. Spasticity is a common sequel to upper motor neuron syndrome. The brain, no longer sending inhibitory signals, allows the muscles to fire uncontrollably. The arm curls inward, the fist clenches, and the foot points down. Over time, the tendons shorten and the joint freezes. The limb becomes a rigid, painful stone. Preventing this requires range of motion or ROM exercises, a daily ritual where the caregiver manually moves the paralyzed limbs through their full arc. This is physically exhausting work. It involves fighting the patient's own muscle tone, gently prying open a clenched fist to clean the palm, which can otherwise become a site of fungal infection and skin breakdown due to trapped moisture. The architectural hostility of the home cannot be overstated. Rugs become tripwires, bathrooms become slip and fall zones. Falls are the leading cause of rehospitalization for stroke survivors. A fall for a patient on blood thinners is a potential hemorrhagic event. The caregiver must audit the home with the eyes of a safety inspector, installing grab bars, removing thresholds, and perhaps arranging for a hospital bed. This transformation of the living space, the intrusion of medical equipment into the bedroom, carries a heavy psychological toll, turning the home into a reminder of illness. Looking to the future, the smart home promises to revolutionize complication prevention. We are seeing the development of smart mattresses embedded with pressure sensors that map the patient's weight distribution in real time, alerting the caregiver's smartphone when a turn is needed, or even automatically adjusting air pockets to relieve pressure points. Wearable biometric socks are being tested to detect the subtle swelling of DVT before it becomes visible to the human eye. AI-driven cameras could monitor gait and balance, predicting a fall risk before it happens. Until then, however,
The prevention of complications relies entirely on the discipline of the caregiver. This entry is an acknowledgement that the stroke does not end when the ambulance leaves. The biological aftershocks continue for months. The caregiver is engaged in a war of attrition against physics, gravity causing bed sores, chemistry, blood clotting, and biology, bacteria in the lungs. Success in this phase is measured in negatives: the bed sore that didn't form, the pneumonia that didn't develop, the fall that didn't happen. It is a thankless, invisible victory, achieved through the relentless, repetitive labor of love and maintenance. It is the grit required to keep the body viable while the brain attempts to heal.
The final entry in the care protocols for a stroke patient is not a task to be completed, but a new way of living to be adopted. Long-term lifestyle and emotional support represents the transition from surviving the event to living with the condition. It is the shift from the acute sprint of emergency medicine to the ultramarathon of chronic disease management. This phase is dominated by two colossal objectives: secondary prevention, stopping the next stroke, and the reconstruction of the self, mental and emotional recovery. The statistics are unforgiving. Nearly 1 in 4 stroke survivors will have another stroke within 5 years. The second stroke is typically more severe, more disabling, and more lethal than the first. Therefore, the caregiver's role evolves into that of a lifestyle architect and a psychological anchor. The cornerstone of long-term care is the rigorous management of vascular risk factors. This is a pharmacological and dietary discipline that must be maintained with religious fervor. Hypertension, high blood pressure, is the single most significant risk factor for stroke recurrence. The caregiver must become an expert in hemodynamics, monitoring blood pressure daily and understanding the pill burden. A stroke survivor may be prescribed a cocktail of medications: antiplatelets, aspirin and Plavix, or anticoagulants, Eliquis or warfarin, to prevent clots, statins, Lipitor to stabilize plaque and lower cholesterol, antihypertensives to relax the vessels, and perhaps insulin for diabetes. Adherence is the challenge. The forgetting curve is steep, and the side effects, bruising, fatigue, muscle aches, tempt patients to skip doses. The caregiver serves as the external frontal lobe, ensuring compliance because a missed dose of a blood thinner can open the window to a catastrophic recurrence in less than 24 hours.
Dietary reconstruction is equally critical and culturally complex. The American diet, high in sodium, processed fats, and sugars, is an engine for vascular destruction. Shifting a patient to a neuroprotective diet, such as the Mediterranean or DASH diet, is a battle against addiction and habit. Sodium is the enemy. It stiffens arteries and raises pressure. The caregiver must become a forensic reader of nutrition labels, hunting for hidden salts in bread, soups, and sauces.
This is not just about cooking vegetables. It is about rewiring the reward centers of the brain that crave salt and sugar. It involves the psychology of deprivation versus the psychology of survival. However, the deepest investigation in this entry belongs to the emotional and psychological crater left by a stroke. We must discuss post-stroke depression, PSD, a condition affecting approximately 1/3 of survivors. This is not merely sadness about being disabled. It is an organic, biological depression caused by the disruption of neurotransmitter pathways, serotonin and norepinephrine, and damage to the mood-regulating centers of the brain. The patient is fighting a chemical war. They may exhibit apathy, a lack of motivation that mimics laziness, but is actually a failure of the brain's executive initiation systems. The caregiver must distinguish between won't and can't. Furthermore, there is the phenomenon of pseudobulbar affect or emotional incontinence. Patients may laugh uncontrollably at a funeral or weep hysterically at a commercial for soap. This disconnection between inner emotion and outer expression is confusing and socially isolating. The caregiver must act as a social buffer, explaining to friends and family that the behavior is neurological, not behavioral. This advocacy is crucial to preventing the social death that often precedes biological death. Isolation is a potent risk factor for mortality. The loneliness toxicity can be as damaging as smoking. The investigation must also touch upon the devastating impact of aphasia. For patients who lose the ability to speak or comprehend language, the world becomes a terrifyingly lonely place. They are trapped in a glass box. The caregiver becomes their voice, their interpreter, and their bridge to humanity. This requires immense patience, waiting 30 seconds for a single word, using picture boards, or learning nonverbal cues. It involves protecting the patient's dignity when they are treated like children by strangers because they cannot articulate their adult thoughts. We must also confront the caregiver burnout syndrome. The long-term care of a stroke patient is a heavy cross to bear. Studies show that caregivers of stroke survivors have higher rates of depression, anxiety, and even cardiovascular disease than the general population. The shift in dynamic from husband/wife or parent/child to nurse/patient can destroy the intimacy of a relationship.
The loss of the partner while the person is still physically present is a complex grief known as ambiguous loss. Long-term support means the caregiver must also support themselves, seeking respite care and therapy to maintain the stamina required for the years ahead. The future of long-term support is bright with the promise of neurotechnology. We are entering the era of brain-computer interfaces, BCI, that may one day allow aphasic patients to speak through computers by decoding their neural thoughts. Implantable stimulators are being tested to treat post-stroke depression by regulating neural firing. Digital therapeutics, prescription video games, and apps are being designed to maintain cognitive sharpness and continue rehabilitation long after insurance stops paying for therapy. The concept of telerehab allows patients to continue their recovery in the metaverse, interacting with other survivors in virtual spaces, breaking the chains of isolation. Ultimately, this final entry encapsulates the philosophy of endurance. Caring for a stroke patient is not a sprint to a cure. It is a commitment to a new version of life. It requires the acceptance that the old person may never fully return, but a new person is there, needing love, dignity, and protection. It is about finding joy in the small victories, the step taken without a cane, the sentence spoken clearly, the blood pressure reading that is finally normal. It is the realization that while the brain is a biological machine susceptible to failure, the human spirit's capacity to adapt and connect is the ultimate neuroprotective force. The caregiver, standing guard over diet, medication, and morale, is the architect of this second chance. They prove that while a stroke can sever the connections between neurons, it cannot sever the connection between human beings.